So I feel like everybody probably has a pretty good handle on what GDV is, or you guys have at least seen some come into the, can you hear me okay?
Yes.
Great. I think you've at least seen some come in through ER. So you should have a fairly good concept of what it looks like, what you're dealing with. The biggest thing I think that happens is that we panic, because we all anticipate that something's coming. It's considered the mother of all emergencies, so until you feel solid about the what to do next, which hopefully you'll feel better after this lecture, you kind of have a sense of, aha, it's coming. So have either one of you gotten past the paper bag stage of bloat? Do you feel confident enough to kind of have a game plan in your head?
I've never seen one come in. I've walked in like as we were euthanizing them, but I've never seen a big one.
Okay. Mary, how about you?
I've definitely seen quite a few of them, but I've seen so many different approaches to it that I don't really know what the proper way is.
Okay. Well, we can talk about some of the differences. Do you care to go see if Nicolette is able to join us? Because she would probably benefit pretty well from this. If she's not, she's not. But so I guess the biggest thing when you're talking about it, hopefully we can clarify it with this lecture, but the biggest thing is time. Time is your enemy when it comes to bloat. So everything has to do with being prepared. And hopefully, like I said, part of preparedness is understanding what to do, and hopefully you'll learn more from this. So when we say bloat, we really mean the full-blown deal, the gastric dilatation-volvulus. Is there a difference between the word actual bloat versus what we make it into meaning? In other words, can you bloat and not go to surgery?
Yes.
So yeah, it's kind of tricky. We tend to interchange the words and say that if you're a GDV, you're bloated and therefore you have to go to surgery. But technically, if you're not V, if you're just gastric dilatation, then you're just a gas-filled belly or sometimes a food bloat. You know, looking at that brand new 12-week-old puppy that got into the fresh bag of food, you can food bloat or gas bloat and not volvulus, not rotate, and not require surgery. So it's important, even on, you'll see some, Chihuahua puppies or some crazy itty-bitty puppy breeds that are hugely bloated in their abdomen, and that's usually due to parasites, some extra fluid in there, sometimes from food as well, combination of things, and that is not the same thing that we're referring to when we talk about bloat. The bloat, the mother of all emergencies, typically implies that the volvulus has already happened, the rotation has already happened, and now you're at a critical mass with what's happening very rapidly inside the abdomen. So just kind of a side note, remember that if somebody says my dog bloated but he went home and he didn't have to have surgery, that is possible, but it was likely food bloat or it was simply gas distension without rotation, because you do not go home from rotation unless you're going home in a body bag or you got surgery. So who does it affect when you're talking about the primary candidates? I think everyone knows it's the bigger breeds. Definitely if you're deep chested, you're on the high list of risk. There's not really a what happens, what causes it. If you read through all the different papers and the studies, and the Germany did a study that's still quoted from 1993. There are other papers that people have done. Basically the bottom line is with bloat, if you're a big dog, if you're deep chested, and genetics plays a pretty good role. There is some argument from the German research back in 93 that says males were 66% more likely, or in their study, 66% were males. So it kind of, numbers can be skewed, and in their study, 66% were males. I don't know why that is, because that's who they found as candidates that were bloated during their research study time. That is why people say that males are more likely to bloat from that study. So I don't know that we can say that. That was a conclusion that I think somebody wrongfully drew from that study. But we do know that it's large breeds. We do know that genetics plays a role. So if the littermate bloats, it's more likely that other littermates will. They tend to hold that genetic predisposition is how they determine it, or what the terminology they use is a genetic predisposition for the greater likelihood of bloating. A couple other breeds that I didn't list here, you could go on and on and on and list breeds, but basically anything that is large, deep-chested, Bassets get to fall on that category. Corgis actually are making their way onto that category. If you think about it, Corgis and Bassets are both really deep-chested dogs. They just cut their legs off. they're just short, so we tend to forget about them. But they're a 35, 45, 55 pound dog, sometimes even bigger than that, and they tend to be just as likely to bloat. So if they are coming in with a pendulous abdomen and some of the symptoms we're about to talk about, then bloat should be on your purview. And when we talk about preventions, if they're truly a volvulus, so remember we said GDV, so if they're just gastric dilatation, then we are going to know that pretty quickly with some of our diagnostics, which we'll talk about in the next couple slides. If it's just gastric dilatation, then surgery is off the table. You don't have to do surgery, but if there is volvulus, if it has rotated, then you don't have an option, and surgery is your number one way of getting in there and fixing it. In terms of not ever bloating, you can surgically tack the stomach. They usually recommend doing that around the time of neutering. And that is simply kind of a quick incision into the abdominal cavity. It's still an invasive procedure. There are still things that can go wrong, but if you're doing it on an otherwise normal, healthy pet, it should be a very quick, certainly easier with a spay because you're already in the abdominal cavity. With a neuter, it's a little more invasive because hopefully you're not going into the abdominal cavity to neuter. But you do a quick incision through a couple layers of the stomach, the outer layers of the wall, a couple nicks in the interior wall lining of the abdominal cavity, and you're just tying those two structures together so that it physically doesn't have the ability of rotating. You can read all about the different techniques, but when you're describing stomach tacking, that is what you're talking about. You're literally tacking a couple stitches surgically, professionally, from the stomach to the abdominal wall to prevent it from being able to rotate if it fills with gas. You can't prevent it from filling with gas. You can do some certain things to try. So that's where you talk about researching. If you're purchasing a high-end breed that's a very specific breed, and you're not looking for a mutt, although it does not exempt you by being a mutt, it does generally have some better hybrid vigor, but it does not, if you're a crossbreed, it doesn't eliminate the chance of bloat. Really, if you're a big breed, if you have a deep chest, you have a chance of bloating. So then we talk about environment and what happens that might decrease their chances. You can read 1,000 different articles on this. Some of the things that everybody tends to agree, and it seems like about every 2 years somebody else has some new thing that they're like, oh my God, ice water caused it. That was one that came up on the radar that somebody somewhere had blogged about, because you have to remember a lot of people that have these really high-end breeds can afford the surgeries, and so they tend to keep a running blog or family of other Irish Wolfhound breed owners. And they all talk amongst themselves online. And so a lot of times you'll get these weird pieces of Dr. Google data out there where somebody somewhere said that ice water is what caused her dog to bloat, and she confirmed it with her vet. And then there were a bunch of haters and arguers that went through and disproved why this couldn't be the case. Things that we do know for sure is it seems to be concentrated around life habits like eating large volumes of food at once. So they recommend spreading out the meals and doing smaller meals interrupted throughout the day. It seems to be more typical with a dry food only diet, so they recommend having a mixture of dry and canned food. It seems to be more common, or history of patients that come in with bloat seem to recurrently have a history of having just recently drunk or eaten a meal and then had a high activity. So they ate or drank and ran outside, or they ran around outside crazy and then came in and ate or drank. So interrupting those behaviors is another preventative tool. Don't race your dog out at the dog park and come straight home and let him drink a full bowl of water. Don't race your dog at the dog park and come home and feed him a full bowl of food. Wait 45 minutes, let the dog calm down, let him have 3 sips of water. I mean, if you're getting a giant breed that's prone to bloating, you have a toddler the rest of your life. Welcome to having a high maintenance breed. But there are things that you can do preventatively. Once it has bloat, the thing that you're doing is driving to the clinic. There's not, I read some fascinating things about how you could do some homeopathic at-home medicines to stop nausea and stop the gassiness, and sure, you can throw those medicines at them all day long as you're driving to the clinic, but I mean, if it's not making it down the esophagus to be absorbed, it might make you feel better, but there's not an at-home treatment for GDV. If it has rotated, there is no at-home treatment. It is get in the car, get to the clinic, and do it fast. So some symptoms that what the owner sees versus what is happening inside. You're going to see some pretty profound discomfort. The owner's going to see that they're pacing, they're panting, their body language is going to be different. They're going to start to hang their head down, their tail is going to be down. The owners often describe dry heaving or retching. It's typically non-productive, or if they produce quote unquote something, it's like a thick white mucousy, ropey disgustingness that is basically accumulated saliva in the length of their esophagus. They're not actually, if it's volvulus, if it's truly rotated, then they are usually unlikely to get any volume out of their stomach. So it's profoundly uncomfortable. It gets more and more painful. You'll see what they call an orthopedic stance. Have you guys heard of an orthopedic stance? Do you know what that is?
No, I'm not sure about that.
Bulldog, I wish I had a picture of it. I wasn't able to find a good picture, but if you Google orthopedic stance and look at the images, it is that classic bulldog with their elbows winging out, and they have a really wide forelimb stance. And what they're doing is expanding their thoracic cavity because the stomach is so full of gas, it's forcing into the diaphragm and putting so much pressure on their lungs they can't breathe. So they're winging their elbows out, broadening their front stance, the only word I know for it. And they're just really doing a wide gait to where they maximize every ounce of lung space because they're so full of gas. You'll typically continue to see the pacing, the panting, and it'll progress to the point that they don't have any energy left and they're so shocky that they collapse. Does anyone know the time frame on when you typically will see all of that transpire from I have a little gas in my stomach, I'm uncomfortable, to I am rotated, I am in trouble, I am in big trouble? Anyone know the timeline?
An hour?
There are some, obviously we don't know exactly what's going on and when, but generally speaking, the general consensus is 20 to 60 minutes. It is very fast. So if you have somebody that's coming, that's why often we know about it ahead of time, which is really helpful. And then often it's imperative that it's rapid assessment, diagnosis, and treatment in the ER. What I would like to see our goal be is if they're going to approve surgery, we should have them from intake to surgery table in under an hour. They should be cutting and derotating in under an hour. And the reason for that is every moment, once that stomach is rotated, what are we compromising?
The intestine, like the oxygen, the blood flow to the tissue?
So blood flow to the stomach, gastric artery, and spleen. And that's why you might have to see a splenectomy along with a bloat surgery. So they do a Epcs secondary to a bloat surgery. First thing you're doing is derotating, and then you're going to Epcs it. But if the spleen was compromised for too long, they derotate, they check everything in the gut, they do their Epcs, and then they check the spleen again. And if the spleen is still angry looking, such that it doesn't seem, whatever their internal marking, whatever the surgeon's marking is in their rule book of what's okay and what's not, if the spleen doesn't look like it's recovered and still is pretty angry, blue, black, and necrosing, then they have to go ahead and remove that. So that's extra time, extra risk, extra complication, and can change some things post-operatively in monitoring. And then if it's prolonged beyond that, you compromise the gastric artery, which means you compromise what? If it feeds the spleen, it feeds, what does the gastric artery feed?
Is it the liver?
Think easier, you're out thinking it. It's the gastric artery, so what is it feeding?
The stomach?
The stomach, exactly. So if you're compromising the gastric artery, then you actually have part of the stomach starting to necrose. It's cut off from blood, it's cut off from oxygen, it's starting to like that nasty gray where you're like, no, that's gonna slough. If your spleen could slough, you would bleed, so we take the whole spleen out. It's very hard to take part of the stomach out. I've seen it done. If you've ever seen an RNA, it's the same concept, but you have a giant balloon ball and you're taking out part of the balloon ball and trying to do the more tissue you involve in a resection, the greater chance by sheer physics that you have a place for it to break down and dehiss and decompensate. So the more gray tissue, more stomach involvement, the more likely you are to euthanize on the table because you simply were rotated for too long and we didn't get in there fast enough. And that's a horrible thing to have to tell an owner who had the financial support to be able to go in and do this surgery, because they still have to pay for that surgery. And every moment that we're delaying, I'm not trying to make us feel bad, I'm just saying that's why we want to be spot on our game, because every moment that it's taking longer to get in there is an increased chance in compromising the integrity of the stomach, and you really can't excise too much of the stomach, and it's very risky and complicates the recovery. So what's happening inside while the owners are seeing all that is that the stomach is distending more and more with gas. There's more pressure on the diaphragm and it gets more painful. The more the gas spills into the stomach, the more likely it is to flip. Now they can't vomit at all, or they get that one little foamy piece of kibble up with a bunch of white ropey nastiness, blade of grass, something like that. And then the gastric artery, plus or minus the spleen, is being cut off, and so shock is at their maximum. When they've collapsed, I mean, there's not like a perfect rule book, playbook that says, okay, they've collapsed, you have 15 minutes till doomsday, but if they're already at the point of collapse, it means they're shocky, and they're shocky to the point that you're gonna be a lot harder getting them back because they're not stable for surgery, and they're one of those that can't be stabilized before you get into surgery, because surgery is the only thing that will fix what's causing the shock. So it's one of those catch-22s, and you have to be really good at your anesthesia if they're already that shocky. So this was something I found which was kind of interesting. There's a billion of these on the internet, but I just wanted to kind of show you some examples. They all put them in different orders, so I wouldn't even begin to tell you what order you'd see them in, but absolutely you're going to start to see a distended abdomen, you're going to start to see some body posture changes, you're going to start to see some retching, but non-productive vomit is the key. When you hear somebody say he's trying to throw up but he hasn't done it, or he can't do it, or I don't think his stomach has anything in it, that it isn't. Have you guys heard bloat, retch? Like, are you familiar with the sound?
Yeah, they just hack and nothing comes.
It is a horrible noise. I mean, it sounds like demons are trying to come out and they won't escape. It is intense. It sounds painful. It hurts me. So it is a very distinctive sound, like parvo has a distinctive smell. If you hear that retching sound, you should be headed up front. If you know that it was a dog that had collapsed, or if you see it coming on camera as a big breed and you hear that noise, you should run up front. Even if they haven't called a tech to the front, run up front. That has a good chance of being a bloat. So excessive drooling, why do they drool? Yeah, hypersalivation is nausea. Pacing, painful. Absolutely. Rapid heart rate and pulse, that's going to come with the shock, that's going to come with the pain. Pulse is going to start to get thready. You're going to start to see some pretty nasty dysrhythmias, and we'll talk about that in a second. So this is body posture, this is what you're going to see. Again, there are lots and lots of these. There's an actually pretty interesting video with a strange voiceover where they watch the dog bloating for like 7 minutes in the backyard. Apparently it survived surgery, because I was about to get real angry while they, like, hi, this is my dog bloating. You can see he's trying to puke and he can't. You can see his abdomen is pendulous. You can see it's filling with more gas. All the while videotaping and not taking it to the vet. But anyway, this is pretty classic posture. So notice head down, abdomen distended, tail down. They're trying to maximize posture. So on the right, you'll see, I think it's on the right on your screen, you see the kind of happy dog, tail up, stomach seems normal. As it starts to fill with gas, it's going to be, uncomfortable. They kind of want to belch or burp, but they can't. And then when it continues to fill with gas, but they can't get any of that pressure off. So it is profoundly painful. They are at their pain tolerance end with it's putting pressure on everything, and they are head down, barely stumbling around, will not sit down because there's no room to sit and pressure rise that stomach anymore. And it's just all they can do to stand. They usually, I've seen very few that even have the energy left to be bitey or snap at you because they're trying to die and they just don't have any energy left to even snap at you. That being said, always take precautions with body language, but they just are profoundly painful. I apologize this is not as clear as I wanted it to be, but again, body posture, what's happening with the stomach is it starts out nice, esophagus up, I just had a moment, sorry. Pylorus down, and then as it's filling with gas, it's going to start to get bigger and bigger, and that pylorus kind of pulls up, and then it just flips. And so when it flips, when you see all the way to the right, you see that kind of ugly gray area on the bottom side. That's where that tissue is dying because the gastric artery is twisted. And it just doesn't end well for the stomach and spleen if you don't get in there. So what do we do as nurses? Again, one of the biggest things is going to be rapid assessment, beginning with the recognition from intake all the way to the back. What do? You hear that noise as triage nurses. You get up there, you turn to your CSRs and say, I need a critical on this one. You don't have to do a whole spiel with bloat to the owner, but you should feel confident about saying, I'm really concerned about how he's acting, about how distended his abdomen is. We really need to rule out whether or not it's bloat or not. I'd like to get him to the back rapidly, and I'll have somebody up to update you very, very soon. I need to get him to the back and get some vitals started. And that's really all you need to say until, unless they're like, no, I won't let you go, I need more information. Most of the time you're going to find people who came for help and they're going to let you take them to the back. And then starting that initial stabilization is so critical. So what do we mean when we talk about initial stabilization? So why would I put radiograph first under stabilized? Because it's not technically stabilization, right? It's technically a diagnostic.
The double bubble?
Exactly. So you need to rule in or rule out the double bubble. How do we get that? What image do we take?
Lateral.
Absolutely. Right or left? Right lateral is our standard. I think probably just because it's easy to lift them up and lay them with the feet towards us, and it's awkward to lay them down feet away. So right lateral is our default, and that's absolutely fine. It is the standard orientation that we look for to recognize a double bubble. If you took a left lateral, you have to flip your brain around and make it think in reverse. But technically you could take a left lateral. It should look weird either way and you should recognize a double bubble. VD is nice. It can give you just exactly how expanded the gas is, but it's not necessary and it's hella uncomfortable for the patient. So the only time I'm gonna get more than a lateral view is if there's been some sort of delay or we already have him in the system such that he has any kind of history of, I don't want to lift a 90-pound dog on the x-ray table twice, so if he's in there, take a set of chest rads if you can. It's not the end-all be-all. If you're confirming bloat and you're pretty sure that they're not going to do the treatment and you just need to confirm it to make him more comfortable until they can make the decision to euthanize, great. But before you go to surgery, you're probably going to want a set of chest rads. Why? I know we don't. I'm sorry?
To see how far everything's being pushed up into the thoracic cavity?
No, nobody cares about that, mainly because your lateral film is literally just confirming that you have the volvulus, confirming that the stomach is rotated. But keep in mind that we have to see the bigger picture. So bloat typically occurs in dogs that are 3 years, but even more likely 7 years and older. So if I have a 7-year-old Great Dane that comes in, I just want to know that he doesn't have cancer in his chest. I don't want to take a dog to surgery for a bloat only to find out he's got snowballs all through his chest. It's happened to us before, not at this practice, but it's just a nice, thorough medicine rule out, especially if the owners have said anything about, well, before he has always had some respiratory problems, so we didn't really think anything of it when he first started, blah, 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 blah. So you just don't want a red herring. Yeah, it absolutely is bloat, confirmed with x-ray. But if this dog is 7, 8, 9, 10, 12 years old and it's a giant breed dog who likely has, by the statistics, 2 to 3 years left, let's just make sure there's not snowballs in the chest. So just being thorough, it's a good idea to take chest rads. I know we don't always do it, but it's a good idea. So I don't care if you get a VD of the abdomen. Yes, that's the best medicine and the most thorough, but if I was picking an order of what I had to get first, I'd get a lateral abdomen, a lateral chest, because neither one of those requires me to stress him on his back. And then if I have anything hokey funky on that lateral chest, then I'm probably gonna get a VD so I can really see left and right lung fields and make sure I don't have snowballs or weirdness. So then what's my next form of stabilization?
Catheter.
Yeah, and usually we place 2. Do you know why?
Is it to give the fluid at a more like bolus rate?
Absolutely. So you can do, typically, one catheter is for your fluid bolus and one catheter is going to be either for a secondary fluid bolus or for the drugs that you're going to need to be given. And if you have dysrhythmias, what drugs are you going to be giving?
Lidocaine?
Absolutely. Absolutely. So 2 catheters, radiograph, IV fluid bolus. Who knows how much fluids you can bolus? What's our standard bolus?
It's not, oh god, I want to say 90 mils per kg, but that sounds too much for a shock bolus.
So that, yes and no. So the amount of fluids that an animal can have in a 24-hour period is based on the formula of 90 mil per kg. You are correct. And that number is taken from their blood volume. A dog's total blood volume is 90 mils per kg. So we can replace their entire blood volume in a crystalloid form in 24 hours. So what we calculate our shock dose at, which we do fast math in ER, so you could do 22.5, but we don't. We do 20. 20 mil per kg is a quarter shock bolus, and that's typically what we start with. So if you have a 50 kg dog, that means you can get a liter of fluids, okay? Basically anything that is 45 to 50 kgs is getting a full liter of fluids. And because they're so down and out, we typically are, I mean, again, we move very quickly with those. That's a situation where we're gonna use the slam bag. Are you guys familiar with what the slam bag is? Or do you use it and not realize that it's called that? So that white bag with the puffy is what we consider the slam bag, and all you're doing is it's like a tool, so you don't have to stand there and squeeze. It does the squeezing for you. You do want to be cautious about a couple things. It can squeeze air into them, so be attentive to that. And you have a little pressure valve at the bottom that tells you when you're in a positive pressure mode, so when you run out of pressure, it will just drip at normal flow rates. So you will have to continue to add the pressure back to it if you are truly trying to slam a full liter. So just be attentive to the fact those 2 things. It can slam air and it can run out of its pressure. But we typically start with that, and then whether or not we trocar, we almost always, I put plus or minus trocar, plus or minus analgesics. Analgesics should almost always be a plus, but pay attention to your timeline because it also might end up being your pre-med. It should be your pre-med if you're able to move successfully quickly, but it's absolutely painful, so you do want some pain meds on board. And then trocaring, have you guys seen trocar? Are you familiar with trocar?
Yeah, that's where they stick the tube, right?
No, so that is actually where you're tubing it into the esophagus and relieving pressure. That works if your esophagus isn't twisted. Typically your esophagus is a little bit angry and you can't get a tube down. If it's volvulus. If it's not volvulus, then yes, you can do like a gastric lavage on a there's arguments for both sides. What is the risk of gastric lavage? Why is it so scary?
Because if the stomach is twisted, you could tear.
So that is certainly a potential side effect would be tearing of the stomach if you're too far in with the tube. But the biggest, scariest risk is that you have to be able to swallow or you have to be all the way knocked out and protect the airway. So it's, if you are running a tube down the stomach and wanting to pump, you typically need them semi-awake, which means they have the ability to choke on your tube, or you need them all the way asleep, which means you have the ability to give them aspiration pneumonia, which is spectacular. The lungs really hate anything from the stomach being in their environment, and they make your body pay for it. And so, puppies can tend to survive bloats that are food bloat only without volvulus a lot faster than older dogs. But if you have to tube them and actually empty their stomach, you better protect that airway. So I actually prefer sedated gastric lavage, but then you add the complication of sedation. So you really have to be spot on with your treatment if you're doing that. Trocar is actually the process of removing the gas, and you are down and dirty shaving a spot high on the left side. So if they're in right lateral, you're shaving the left lateral abdomen, basically where the bubble is. You are shaving, you are alcoholing, and you are jabbing a 14 gauge catheter into it and letting that gas off. Now, one alternative way of doing it is kind of interesting. How do you know you hit it? Well, you can smell it, and then you can pass out or gag. Or, alternatively, one cool way of doing it that Dr. Jones showed us is that you can actually attach an extension set to it and run the end of the extension set into a bowl of water, and it will bubble, and you will physically see the bubbles coming out. And you can get liquid, because depending on what they ate or what they drank or what's in the stomach, you will potentially start to get some content out. But basically it's an emergency procedure to take the maximum amount of gas off to relieve some temporary pressure, because they can't pass it through their pylorus very well. They can't burp it or belch it or vomit it up, and it's continuing to maximize pressure. So if you need a stopgap relief now, or owners haven't quite committed to euthanizing or surgery and they're on the fence, you can't go to surgery yet to fix it, trocaring can buy you a little bit of time and buy the spleen and gastric tissues a little bit of time. But it's down, it's sturdy, and you've stuck a hole in a giant fluid-filled structure, so you potentially have leakage into the abdomen. Not a lot, but it can happen. You're using a giant gauge needle to quickly get rid of some stuff, so there are side effects. And then the biggest thing is plan for surgery. So planning ahead, knowing that you're going to be using surgery. A lot of times you'll see us, oh, we've got a blood on the way, might as well set up surgery. It's kind of like that, what do we always say? If you set up surgery, you won't go. If you don't set it up, you'll need it. So just plan ahead, expect that you'll need it, and if not, hey, it's ready for the next one, that 3 a.m. C-section. But it is a good idea to go ahead and have surgery ready, so you're not running around trying to do it all while prepping your patient. So what initial vitals can we plan on and take? All initial vitals, all vitals are important, baseline and repeating. It's important to specifically focus on and pay attention to the BP, an EKG, what the pulses are doing, and what their mucous membranes are doing. So initially, that we always talk about the trends. I know you've heard me preach about the trends. It's not a single piece of data. So when you do a baseline, make sure you're writing down an intake time, because it's not a baseline. A baseline doesn't help me if I don't know, was that the one that we triaged at 1 in the afternoon, or is that the one we wrote down at 7 p.m. because that's when we started his flow sheet? There needs to be a timeline linked to when that actual set of vitals was. Because you're looking at the big picture. So if you have heart rate at 200 and it's written down at 7 p.m. because that's when the treatment flow sheet started, but we actually gave pain meds at 3 after the 1 p.m. intake or whatever, that's reflected on not on those vitals, so somebody could mistake things. So you want to make sure your timeline is accurate, and then those repeat every 10, 15 minutes, checking things after a bolus, checking things after pain meds. Anytime you've done some sort of treatment, you want to see if you have effect on the vital that is giving you the most concern. So getting a baseline BP is really important. Looking at the EKG, what abnormality might you see on an EKG?
VPCs?
Absolutely, absolutely. So you might see some ventricular precontractions or premature ventricular complexes. I don't know, depending which cardiologist you talk to, they like to rename it every so often to keep us confused, I think. But basically it's and I'm kind of suck at cardio, so here's my weakness, so y'all bear with me. It is where it does not start in the AV node, right? Stephanie, correct me. A VPC, instead of the atrium and the ventricle contracting, it skips the AV node and it just somewhere just creates its own electricity and just does this really wide, is this? Yeah. So it looks like a giant V, inverted and regular on an actual EKG. It's typically wider than your QRS complex, and it doesn't originate in the AV node, so it's not a true contraction, it's like a fluttery half contraction. The argument to treat or not to treat is usually based on heart rate, but if you're seeing those VPCs initially on intake, then you're typically going to give some lidocaine boluses. On your heart rate, you will typically see it initially elevated, but it will start to get weaker. Your pulses will start out bounding and then become thready or non-synchronous. Your mucous membranes start out really injected in red and then will move to pale as they become more shocky. So again, the stage at which you are in matters, and it all progresses really quickly. Whoa, what happened? Is that right? No. Sorry, I missed one. So diagnostics, you are going to do blood work and radiographs. When we talk about, we kind of already talked about this a little bit with the radiographs and why you would take additional full rads. With blood work, we typically do want either a lactate, some sort of renal value, and a PCV total solids is typically on those. Whether it's a CG8 or an EC8 or an ISTAT or a big, whatever it is, whatever the name of the test is, it's important to know why you're taking it and why you want it. What they typically look for are the lactate and the hydration status. A renal value lets you know that your kidneys are working. They are older dogs. Ideally, you would run a pre-op blood work if you have your doctor has a preference. If it's a full CBC chem light's great. If it's a just pre-operative blood work, which doesn't necessarily get all of them, fine. What you're looking at initially is the lactate and the hydration status. PCV is helpful, but those are the primary things you're looking at, knowing that their kidneys are successfully working. But basically, it's not going to be a big indicator of whether you're going to surgery or not. You shouldn't have. There used to be a big argument about what your lactate level was and whether it was indicative of your recovery chances. And so it used to be, I think normal lactate is what, 1 to 1.5 or something like that. A measurement of the lactic acid that's built up into your body. Typically, you would see bloats that are around the 5 to 6 if you caught them early. The longer they bloated, then you might be seeing them in the 10s and 12s. We've seen them up in the 15s and 17s. They argue back and forth on whether or not elevated lactates are diagnostic indicators for success of surgical positive outcome. And really, I should have asked Dr. Peck ahead of time if he had an opinion about it, but I feel like judging an entire case based on one value is an unfair reality. And I have seen them go to surgery on a 12 and it survive, and I've seen them go to surgery on a 5 and it not. So they have really fallen out of favor with arguing based on a lactate being an end-all be-all, but they do still like to know. It does talk about how much muscle damage there has been, so it is an interesting value, but we don't put as much stock in like, oh, this one won't survive because it's a 16. Full labs, they're nice. Radiographs, chest is nice, especially if you have any concerns about age and cancer, but lateral is your big one as far as what's diagnostic for confirming. So when we talk about a radiograph, what do we see? Double bubble, right? I wish I could show you can you see my mouse?
Yeah.
Oh, fascinating. Cool. So I can use it like a pointer, even if it's slow motion? Okay. So you can see where the big body of the stomach is, and then up here is where this pylorus has flipped on top of itself up along the spine and is now rotating over. And I don't know if you can see it superimposed, but this is the esophagus itself. So the pylorus sort of kisses the esophagus now, where it should have been coming out down here. It fills up, gets fuller and fuller, and flops up against this. So the spleen is now right here, pulling underneath. The spleen should have been up here, right here. Now it's down here at the bottom. So you've twisted and pulled all of that artery that runs on the back side, I don't remember, along the greater curvature, I guess, of the stomach. Really pulling on my anatomy and physiology. But you're twisting it, it's pulling it all the way up and around, and it's really pissing off the spleen and the stomach, and the more it stretches, the more it compromises, etc., etc. I have some cool animations. I'm sorry, they may not all come through. I don't know what's happening with this slide. Oh, because I said you had to click on it. So these were just a bunch more pictures of awesome bloats that I found. Not sure what happened there, sorry. I shouldn't be turned loose with animations. So again, the one on the right, to me, it's obviously a bloat, but then also it has that weird shadowing in the middle. I literally just think it's the way the stomach's folded and the fact that there's more gas in the proximal pylorus, so closest to the stomach, but because it's folded, it's showing kind of a weird effect, and the echogenicity changes, but both of those are bloat. You could take 100 pictures of bloat and none of them would look identical, but they would all have that characteristic pylorus on top, and the pylorus is not supposed to be on top. So if your pylorus is next to your spine, you're rotated. Oh, this is my funny. So if you don't call it a double bubble, old school, what do we call it? Come on, Stephanie, help me out.
Is it the Smurf hat?
Yes, thank you, good job. This is why we call it a Smurf hat if you didn't watch the Smurfs. So it clearly looks like there's a damn Smurf inside this dog. All you have to do is like draw a little nose. Can't you just see like a little nose here, little eyeballs? I'm sure somebody animated this and somebody's good at like graphics. But Whitney, we need a cool GIF on this. GIF, whatever it is. We'll take a poll on how you're supposed to pronounce it. Anyway, so basically you have 3 stages. You have the pre-operative, you have the operative, and you have the post-operative that you're dealing with. And in ER land, we deal with, at least for the intake side, where you guys are doing the most of, the audience that's currently here, you guys are primarily handling the pre-operative intake, rapid acting, let's get this done and get this guy stable, or keep him stable till the owners can make a decision. So bilateral IV catheters, crystalloid fluid boluses, we talked about what a standard bolus is, good job. 90 mil per kg, so 20 mil per kg is your quarter shock bolus, that's where you start. You can repeat that up to, you can technically repeat it up to 4 times, but we usually only do 2, possibly a third, and then the rest is like intraoperative and then post-operative. And if you're truly seeing pressure issues, then we should be treating with a colloid, but it's typically you're just trying to dilute the shockiness that's happening because your pressure theoretically would be normal or high because you're squishing off one of your arteries. So you haven't lost volume. You will lose that volume as soon as it's derotated, and we'll talk about that in just a moment on the next slide. So may or may not need a lidocaine bolus. How would we know? Because we did our right monitoring equipment and we see what abnormality on an EKG?
VPCs.
Excellent. So if you're seeing VPCs, point it out to the doctor, ask if they want a lidocaine bolus. We'll talk about how much you're supposed to give here in a minute, but be solid with your dosing, have it ready, write it down on your cheat sheet in your pocket guide, know what you need to give. Trocar, it can relieve, like we talked about, pressure temporarily. It's not an end-all be-all, it doesn't fix it. It just takes some pressure off and buys you some time. Pain meds, monitor, monitor, monitor. I cannot say monitoring enough at every stage with the bloat. Because whether or not you're giving multiple lidocaine boluses, something you might, I don't have it committed to memory, but something you might want to write down for the sake of every bloat you ever have to deal with. What is your toxic or your maximum daily dose of lidocaine that you can achieve? Because you might have to give a couple additional boluses. Usually, from my experience, if you have to do a second bolus, you typically are starting a CRI. Because you just know that you're going to anticipate more VPCs and need another one. And so rather than give multiple interrupted, you're going to do a CRI. However, a CRI is the same as a one-time bolus. It's a 2 mg per kg per hour or a 2 mg per kg per now bolus. So theoretically, 1 per hour is acceptable, but if you've had to repeat it twice in an hour, you've basically double dosed, and so you do want to be cautious with your lidocaine usage. So actually during the operation or leading up to it, I guess perioperatively, you're going to make sure you're sedating, you have your table and everything ready. Again, preparedness, having the OR set up, if you're going to trocar, it's nice to go ahead and shave as much as the abdomen as you can get to. Again, these patients are so sick that they are not really caring that you have clippers turned on near their body. They don't give 2 shits. So you can typically, if they're still standing, you can shave while you're on your head, upside down, and get as much shaved as possible, and then you have decreased the time from prep table to cut table. Pay attention to what meds you used preoperatively, because you are likely to start them on a fentanyl lidocaine, because fentanyl is great pain control and lidocaine is necessary for your VPCs, and they work so nicely together. So having those common doses in your mind is great. Don't forget about the fact that you need a bucket, a tube, and a pump. All of that, everybody knows where that lives?
I don't think I do, actually.
Underneath the table and triage.
Correct. So if you're standing facing the half kennels and the Dr. Fishbowl with your back against, or back facing the, what do you call that? The like triage nursing station, the triage row of computers. If you're standing at that first treatment table that has the trash can door, the door to the right of that has the gastric bucket and a bunch of different choices on tubes and should have the gastric pump. I think we only have one gastric pump.
And it's labeled.
And it's labeled on the door and it should always be there, and you will hear about it on home base if somebody moves it, because it should stay there. That's its permanent location. That's where we look for it. So it requires all three of those, and typically you fill the bucket up with warm water because you're going to pump it in. When the doctor tells you to pass the tube, you're going to pump it in, and then it's going to drain out into your bucket, and it'll be this slimy, disgusting, awful, foul smelling nastiness of grass and kibble, half digested if you're lucky. And it's a bit of a nightmare, but it does work, and there's kind of some finesse to it. Don't forget that you need to be prepared to do blood pressures, and be prepared for that blood pressure dropping like we talked about. Why does it drop? What physical thing happens?
When you untwist the stomach.
Absolutely. It's like having a rubber band on your finger and then you suddenly remove the rubber band and your finger gushes blood to the tip and you get that pulsing sensation because you've opened up that vessel. The same thing happens in the abdomen, but in this case, the full blood pressure of the periphery drops because you no longer have constricted something. So you'll just see a rapid response to that, and because it's no longer as painful, your patient basically settles a lot better, and so you may require less fentanyl lidocaine or less gas anesthesia. You may require a little bit of a fluid bolus at that point, but just pay attention to your, anticipate that so you're not panicking. If your PET was on 2.5 and you're on an FL, you probably can drop them to 1.5 or 2. If you are getting some pressures down in the 90s, you'll probably get pressures in the 50s or 60s when they first rotate. So it'll take you a little time to compensate. So just anticipate that, don't panic, you know what's gonna happen, but take steps to be prepared for it. So again, monitoring. And then getting out of surgery, and this is true of any patient, but the faster you can get out of surgery, the less time you're spending with an old geriatric patient getting cold, open abdomen time, all of those things. If you can get them out of surgery pretty rapidly, that is crucial. Obviously, if the spleen is involved, you've tacked on extra minutes. If the stomach is involved, you may be making that critical call of euthanizing on the table. But most of the time, it's a pretty quick surgery. You're just derotating, shoving the tube in, lavaging everything out, tacking the stomach, checking for anything weird because you're in there and why not, and then sewing them up and getting them off the table. And then that leads us to the post-operative care, which is almost invariably consistently keeping them on the fentanyl lidocaine plus or minus ketamine, again, up to your doctor. What are some specific, we talked about this, again, you're still looking for VPC, so what are you gonna hook them up to post-operatively?
Lidocaine.
Well, they're already on the lidocaine, but for monitoring equipment, what are we gonna hook them up to?
The EKG.
EKG.
Yeah, absolutely. And so for the sake of comfort and the fact that it's long-term, you're gonna have them on the what the hell is it called? Telemetry. These guys are usually an ASA 3 to 4, most of them probably being a 4 unless it was a really simple, and I hate that word for surgery, but if it was a non-complicated, easy, rapidly in there, literally no complications, you might be able to call it a 3 post-op, but most of the time a GDV post-op is still a 4 for at least the first 6 to 12 hours post-op. That means intense monitoring. You're really paying attention to like titrating things up and down, paying attention to his pain needs, his BP needs, his temperature needs. You're really focusing on some things. And then of course, if you've removed the spleen or there was a partial gastrectomy, you've upped the game on their nursing care and their kind of post, how long they're going to be in the hospital. I just realized I had a spelling error, but that's fine. Monitoring is still really, really critical on these patients, so do not forget the importance of monitoring. So a couple things I pulled off the web on a study. Great Dane was considered the number 1. St. Bernard was considered the number 2. Weimaraner came in at number 3. That was a more recent study, and the older study in 1993 still had German Shepherd and Boxer as the highest risk for bloat. Again, you can skew any numbers. If you pull 100 dog owners and 93 of them are Boxers, then you're going to get predominantly Boxer. So you'd have to have depends on how you do the stats, but we all know that those really big breeds have really high chances. So if a Yorkie comes in with that horrible cough, it's not really high on my list of having bloated. But if it's a Corgi, if it's a Basset, if it's any of the breeds we've talked about, it's on my purview for bloat. So this just shows you a normal stomach, where it should be, one up, one down. You should have that nice esophagus, you should have that nice pylorus coming down. When that pylorus starts filling and the stomach starts filling, up comes the pylorus over, flipped around, and the spleen is over here by the word body. It's on this back side, the high side, the greater curvature, and it folds to the downside, and you've twisted this whole beautiful artery along the fundus and greater curvature of the body and that whole thing. And you usually see your worst damage down here on this bottom part. Can you see my mouse? No. Anyway, on the bottom part near the pylorus of the greater curvature is where you're going to see your worst damage typically. And it's just not a great place to have to resection. So time, fast. So here's what they had to say in terms of VIN on what you need to worry about and an example of some VPCs. So the top one shows you some pretty decent QRSs, no problems, and then bam, some even prettier QRSs on the bottom right, and then bam, in the middle, your VPC. So again, it's wider, it's not coming from the AV node. It is not generated as an electrical impulse from the atrium. It is just ventricular spasms, so to speak. They call it a dangerous dysrhythmia. Basically, they attributed it to about 38% mortality rate. So pay attention, one up your game, have your doses ready. This is just the clinical definition of VPCs according to Dr. Matthew Miller, who has all this alphabet soup and is a board certified criticalist in cardiology. Again, I can share all these notes with you. It hurts my brain, but it gives you some really good discussion. I love when they tell you that it's in the refractory period of the physiologic AV dissociation. Brain melted. Cardiology is not my thing. So when we talk about lidocaine, I told you we do a 2 mg per kg bolus. That is if you're seeing those VPCs present because we've got them hooked up to an EKG. When we do a CRI, we're typically doing 1.5 to 2 mg per kg per hour. So if you know your CRI math, let's say our dog is 30 kgs, how much would your bolus be? I want a 2 mg per kg, he's 30 kgs. 60 mgs. And what is my concentration of lidocaine? What does it say on the math test that you've taken or on the bottle if you recall it? Lidocaine is always labeled as a percentage. It always says 2% lidocaine. And how do we convert percentage to mg per mil?
It's 2 grams over 100 mils. It would be 20 milligrams per mil.
Damn students and all their fancy math. Okay, the cheat sheet, you are correct, Abby, great job. The cheater way of doing it is take any percent and add a 0 and that becomes your mgs per mil. Yes, you stated the correct mathematical formula, but the cheater way, the fast math way, is if you have 2%, put a 0 next to the 2, that's 20 mg per mil. If you have 10%, put a 0 next to the 10, that's 100 mg per mil. So lidocaine is 20 mg per mil. If we need 60 milligrams and it comes in 20 mg per mil, how many mils do we need?
3.
3 mils. So 3 mils is our bolus, and a little bit less than 3 mils or up to 3 mils per hour is our CRI rate. So, I forgot I did this clicky stuff. So 3 mils, look at me with my animations. Go, Becky. So our CRI rate is going to be very similar. So if we say 1.5 to 2 mg per kg, well, if 3 mils, again, here's my fast math, Becky math. If 3 mils is a 2 mg per kg, then 1 mg per kg is 1.5 mils, right? We can all agree that is the case?
Yes.
2 mgs is 3 mils, so 1 meg is half of that, 1.5 mils. So if I want a 1.5 to 2 mg per kg per hour, then half a milligram is half of 1.5 mils. Everybody follow that? So 0.75 mils is added back to the 1.5 to give me 1.5 mgs, which is translates to 2.25. I just rounded it to 2.3 because nobody's giving 5/100ths of a drug. But did everybody follow that math? I didn't write it out, but okay. So your range, your hourly range of lidocaine is 2.3 to 3 mils per hour. So if we are doing a fentanyl lidocaine CRI, fentanyl at 4 mic per kg per hour comes out to 2.4 mils. Why? Because he's 30 kg, so 1 mic per kg is 30 mics, right? 1 mic per kg, 30 kgs, that's 30 micrograms. Fentanyl is 50 mic per mil. 30 over 50 is 0.6. Everyone agrees?
Yes.
So 0.6 mils per hour of fentanyl gives this dog a mic per kg per hour. So if I want 4 mics, I times 0.6 by 4. That gives me 2.4 mils. Will 2.4 mils of lidocaine fall within my range of 1.5 to 2 mgs per kg?
Yes.
It will. So that is why I tell you, if you calculate a 4 mic per kg per hour of fentanyl for any patient, you can safely double that volume for lidocaine, and that is how much you give. So if your dose of fentanyl, pure dose, undiluted of fentanyl is 0.5 ml an hour at 4 mics per kg, then I would recommend 0.5 ml an hour of lidocaine for so whatever your syringe is, 10 ml syringe, 5 mils of lidocaine, 5 mils of fentanyl, total volume of 10, run it at 1 mil per hour, and you are delivering a 4 mic per kg and a, whatever I just said, 2.3, excuse me, a 1.6 essentially, somewhere between 1.5 to 2 mgs per kg of lidocaine. If you double your 4 mic per kg dose of fentanyl volume and make it lidocaine, then you will always have a 1-to-1 ratio and you will always safely dose the lidocaine while you're dosing the fentanyl. Did that confuse anyone? Did I make that worse or better?
No, it was good.
Okay, so that's just your fast down and dirty math. If you calculate your lidocaine, great. If you're scared of calculating the lidocaine, calculate your fentanyl at 4 mics per kg per hour, and whatever that volume is the same volume of lidocaine, as long as your lidocaine, which I've never seen lidocaine that isn't, but always double check, as long as your lidocaine is 2% or 20 mg per mil, the volume always works out, the math always works out. So in conclusion, rapid assessment, rapid action, being prepared, having a plan in place, monitor, 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 don't panic, you can do this.